Good morning, everybody. I would like to thank the ISOT Scientific Committee for giving me this opportunity to be here. I will be speaking on impact of CYP3A5 expression on clinical outcomes in renal transplant recipients receiving Tacrolimus. So this is the outline for my talk. Tacrolimus, as we know, is the preferred CNI for maintenance immunosuppression in patients undergoing kidney transplantation. But as we know, it has a narrow therapeutic window, and it can lead to various toxicities if not monitored closely. How is tacrolimus metabolized in human body? In human body, the tacrolimus is metabolized with the help of cytochrome P450 3A family. How we do name these enzymes? Every enzyme is named according to a family number, that is CYP3, a subfamily letter, that is A in this example, and an individual enzyme number, that is 5. And then we have the allelic variant represented after an asterisk. So it is CYP3A5 1. In humans, CYP3A4 and CYP3A5 are mainly responsible for metabolism of tacrolimus in the intestinal mucosa and as well as in the hepatic cells. Substitution of G for A at position 6986 results in a non-functional protein. So, with respect to the activity of CYP3 enzymes, it is CYP3A5 1 which has the maximum enzyme activity, and the 3 allelic variant has the least, or they are also known as the non-expressors of CYP3A5. So, patients with CYP3A5 1 allelic variant will have fast tacrolimus clearance and will require higher dose of the tacrolimus, whereas those with the 3 allelic variant will have the lowest dose requirement, and those heterozygous having the 1 and 3 allele will have a intermediate metabolism. What is the frequency of polymorphism, CYP3A polymorphism, that we commonly see in our population? So this is from one of the meta-analysis. So majority of the Caucasian population are assumed to be non-expressors, and the Indian population comes somewhere in between regarding the distribution. So when we look at the Indian data, these are data from South India, from western part of India, this is from North India, and the last data is from our own center. So what we find is around 50 to 60% of the patients in our population are CYP3A5 non-expressors, and rest of the majority patients fall in the intermediate metabolizer or intermediate expressor phenotype, and very few of patients from our population have CYP3A5 expressor status. So how does CYP3A5 polymorphism affect tacrolimus dose requirement? As per the CPIC guideline, the extensive metabolizer, that is the CYP3A5 1 phenotype, are expected to require 1.5 to 2 times the normal recommended dose of tacrolimus, and those patients who are poor metabolizers should be given a dose of 0.1 mg per kg per day, and the intermediate persons will have the dose requirement somewhere in between the two extremes. But does this hold true for our population? So now we have significant data from our own population, the Indian study population. So what we find that from our own data, we found that majority of the expressors will require a dose somewhere around 0.08 to 0.1 mg per kg per day, which also was shown by data from the Western India. From northern part of the India, a study by Dr. Narayan Prasad sir, it showed that the expressors will require a dose of around 0.13 mg per kg, and the non-expressors will require a dose around 0.11. Whereas our population, we find that mainly patients from central India and western India, we find that the non-expressors require much lower doses of tacrolimus, that is somewhere around 0.05 mg per kg per day. Another study from South India did not report the dosages on the mg per kg, but even if we assume the average weight of adult patients around 60 mg, we get this dose requirement to somewhere around 0.04 to 0.05 mg per kg per day. Another important aspect when we consider the pharmacokinetics of tacrolimus is the C0 by D, which is independent of the body weight, that is the trough level divided by the dose of tacrolimus that is being given and in the mg per kg per day. So, CYP3A5 expressors will have significantly lower tacrolimus C0 by D as compared to the expressors. The Indian data that we have from us, this is from this study by Dr. Fernando from the South India. We showed significantly higher C0 by D of tacrolimus in non-expressors, and this was also replicated in the North Indian study and study from our center as well. In another study from South India, they tried to develop a model, a predictive model based on the pharmacogenomics, and depending on this model, if we target a C0 of 10 nanogram per ml, that which is common range in the early post-transplantation period, it again gives us a dose of 0.12 mg per kg for the expressors and a dose range around 0.06 mg per kg for the non-expressor phenotypes. Another study examined whether we can achieve the target tacrolimus levels if we adopt a genotype based dosing rather than going by the empiric dosing that we start at 0.1 mg per kg per day. And what they found that genotype based dosing was able to achieve the target C0 levels earlier, requiring lesser dose modification and lesser number of tacrolimus dose monitorings. Does this hold true when we are switching our patient to OD or the extended release tacrolimus? It does hold true. CYP3A5 expressors had significantly lower C0 by D even with extended release formulations. In another study, when patients were switched over from BD tacrolimus to OD tacrolimus, they found that CYP3A5 expressors required almost 50% extra dose as compared to the total dose that they were getting on the BD dose profile. So what we generally assume that say patient is getting 3 mg per kg of tacrolimus in the BD dose, if we switch over to OD, we should be needing the same dose, that is 3 mg per kg. But if the patients are CYP3A5 expressors, they probably required to go for 4.5 or 4 to 5 mg of tacrolimus OD. And for the non-expressor, it will be something like 3.5 to 4 mg when we switch over to OD dosing. Does it affect graft rejection? There has been various studies. The smaller studies have been inconclusive, some pointing that expressors may have increased risk of rejections, and whereas non-expressors having lesser risk of rejection. This is a recent study, a very interesting study. They studied the development of anti-HLA antibodies, whether CYP3A5 expressor or non-expressor phenotype had a effect on development of anti-HLA antibodies after transplant. So what they found was the significantly higher number of patients developing anti-HLA antibodies in the CYP3A5 expressor group for class 2 anti-HLA antibodies. The difference was just assuming significance, and this also translated into a increased risk of antibody mediated rejection in CYP3A5 expressors over a 5-year follow-up period, but there was no difference in the incidence of TCMR. Another meta-analysis by Khan and colleagues showed that CYP3A5 non-expressors have a lower risk of rejection at 1 year, and which may translate into a lower risk of rejection at 3 and 5 years of follow-up. Are there any ethnic differences when we compare these results? So what they found was Asian patients are probably more likely to benefit the CYP3A5 non-expressors. Asian patients may be at a lower risk of rejection as compared to the European population. Does this affect tacrolimus toxicity? There was one study where they studied the expression of the pro-fibrotic milieu in the tubular cells, and it was found that the donor CYP3A5 non-expressor or expressor status was associated with the development of profibrotic milieu in these patients. Another study from Thailand, they found that donor CYP3A5 non-expressor genotype, donor having a non-expressor genotype, may be at a risk of CNI nephrotoxicity. So not only the recipient genotype, the donor genotype may have some bearing on the development of tacrolimus toxicity. Does it affect the incidence of infection? Major big studies have not clearly shown that CYP expressor or non-expressor status can affect the risk of infection. There has been some small data from small case series from India which said that there is increased risk of tuberculosis in CYP non-expressor, probably related to overdosing or the achieving of higher trough levels in non-expressors. Another study published last year in IJT only, which was presented in last year ISOT Congress, also showed a slightly increased risk of infection in non-expressors. Does it affect the CYP3 affect the pediatric patients undergoing transplantation? There are no large scale studies or large scale data, but small studies from various groups also said that the same findings that we find in the adult patients do hold true when we are transplanting our pediatric patients as well. Can CYP affect the tacrolimus and other drug interactions? So in one of the studies from China, they found that the CYP non-expressor group had significantly higher trough levels after introduction of posaconazole. So these patients who were expressor did not have significant increase in tacrolimus levels, but the increase in tacrolimus level after posaconazole addition was much higher in the non-expressor phenotype. Same was also found in the interaction between tacrolimus and amlodipine. The last thing for my talk is the are we justified in doing a CYP3A phenotype or genotyping for all our patients? Because as a society, as Madam also was speaking, we are cost conscious society. So are we justified in doing CYP for all our patients, or we should restrict it to a selected group of patients? So on an average, it costs around 4,000 rupees to do a CYP3A5 polymorphism analysis. And as we discussed, if we start tacrolimus at a dose of 0.1 mg per kg, the average cost per month of therapy is around rupees 8,000. And if we can start, if we are sure that this is a non-expressor patient and we can safely start the tacrolimus at 0.05 mg per kg per day, we recover the cost of doing analysis just in 1 month of therapy. And what we save more is the cost of doing a kidney biopsy, cost of doing repeated tacrolimus analysis. So in conclusion, genetic polymorphism in our society is widely prevalent. CYP3A5 non-expressors require lower tacrolimus dose than expressors. It does affect the dose requirement across age and across the formulation, whether we are using the extended release or the BD formulation. CYP3A5 expressors may face higher risk of kidney rejection, and non-expressors may be at increased risk of tacrolimus related toxicity or drug interactions and probably infections. Thank you.